welcome to the Deep Dive. Today, we're looking at something that's really fundamentally changing how we approach emergency calls.
Hmm.
It's this growing population of patients, the ones with chronic, complex needs.
Right.
But they're living long lives,
Mm.
often outside of hospitals, at home.
It really is the new normal, thanks to, well, huge leaps in medical tech and, the push to decrease hospital stays for cost reasons.
Yeah, shorter stays are definitely a factor.
It means more children, more adults are at home, but they're dependent on equipment, specialized care that, frankly, used to only happen in an ICU setting.
So we're potentially managing ventilators, complex 4B pumps,
Hmm.
even cardiac devices right there in someone's living room.
Exactly. And our mission today really is to help you cut through that complexity, give you the essentials for success.
The basics still apply, though, right?
Yeah.
XABCs.
Oh, absolutely. The fundamentals of assessment, triage, resuscitation, they don't change. The big challenge is adapting. Specifically, it's about not getting lost in the noise and mechanics of all the equipment.
Focus on the patient.
Relentlessly. Focus on the patient and understand their unique baseline. What's normal for them?
And I think there's a key resource here. Beyond the clinical stuff,
Definitely.
the patient's primary caregiver. They're the real experts on that patient's condition, aren't they?
Absolutely critical. In many high-risk situations, these caregivers even have a go bag ready. Spare parts, supplies, documentation.
Ready to hand off.
Exactly. Using that established system, tapping into their knowledge, it's just non-negotiable for good care.
Okay, maybe we should start with neurological differences. Communication is often the first hurdle there.
Makes sense. Where do we begin?
Well, let's start broad with developmental disability. That's the umbrella term. It covers any condition that impairs development. Could be physical ability, learning, language, even coping skills.
And intellectual disability fits under that umbrella.
Yes, it's a specific subset. It involves significant limits in intellectual functioning and those daily living skills. Importantly, it's diagnosed before age 18. And it's a huge spectrum, mild to profound. Right, so imagine you arrive on scene. Strangers, uniforms, maybe lights and sirens. That disruption alone must be huge.
It can be overwhelming instantly, a massive break in their routine, regardless of the specific diagnosis. The key is a calm approach. Explain everything you're doing, respect their routines as much as possible.
But clinically, how do you assess pain? If they can't just tell you, it hurts here.
That's where the caregiver is vital again. You have to ask them how the patient communicates.
Do they use words, pictures,
Yeah.
gestures?
Exactly. Or are they generally non-communicative? That caregiver input is often the only way you'll get a baseline for comfort versus distress.
And a quick point on language here, too.
Oh, yes. Crucial. Use the correct term. Intellectual disability. Avoid any outdated or, frankly, inappropriate language in your interactions and your reports. It matters.
Okay, let's pivot slightly to autism spectrum disorder, ASD.
Right. Defined by deficits in social communication and interaction, and also those restricted repetitive behaviors you sometimes see.
Prevalence is around 1 in 40 people.
Roughly, yes, and often diagnosed about 3 to 4 times more often in males.
What's something surprising providers might encounter with ASD?
I think the sensory responses can be really unexpected. Many patients with ASD don't process sensations like pain, heat, or cold in a typical way.
How so?
Well, we've seen cases where a patient experiencing significant pain might react by laughing, or humming, singing, even compulsively taking off clothes.
Wow.
Conversely, they might not feel cold or heat normally, which could mask something like hypothermia or heat stroke.
So that completely changes how you interpret your assessment findings. A patient smiling doesn't necessarily mean they aren't in severe distress.
Precisely. You have to look beyond the surface behavior.
So what are some practical tips for managing that?
Okay, tactically. When you examine, maybe start at the feet and move up. Explain each step clearly.
Minimize stimulation.
Definitely. Lower the lights if possible. Limit siren use nearby if it's safe. Use short, direct, simple phrases. Give them extra time to process what you're asking.
And having a family member nearby.
Huge help. If your policy allows it, having a trusted caregiver or family member ride along can massively reduce anxiety and make the whole transfer smoother.
Let's touch on Down syndrome, trisomy 21.
Ah.
There are physical characteristics that impact us, right?
Yes. Beyond any intellectual component, there are physical things to be aware of, like the round head with a flat back, the occiput. An enlarged, protruding tongue is common, and often smaller mouths and nasal cavities.
Which sounds like an immediate airway concern.
It is. It's an airway alert. That combination, large tongue, small features, can make getting a seal with a bag mask really challenging.
What about obstructions?
Sometimes, if you encounter an obstruction and there's no trauma involved, remember that just a simple jaw thrust maneuver might be enough to lift the tongue and clear the airway.
That brings up trauma. There's a specific risk with Down syndrome, isn't there?
Yes, atlantoaxial instability, or AAI.
Okay.
Up to 15% of individuals with Down syndrome have this. It's an unstable joint between C1 and C2, the first two neck vertebrae.
And why is that instability so dangerous for us?
It means that joint is, well, looser than it should be. So any significant trauma, especially anything involving forceful bending forward or backward of the neck, hyperflexion, hyperextension,
Right?
could cause those vertebrae to shift. Even shear, that can cause immediate severe spinal cord damage.
So extreme caution with C-spine immobilization is needed.
Absolutely. And if you do need an airway maneuver, think minimally invasive first. Like that jaw thrust we mentioned. It's a balance protecting the spine versus ensuring a patent airway right now.
That balancing act, knowing about that specific anatomical risk, that's exactly why this kind of deep dive is important.
Absolutely. It changes your approach.
Oh, okay. Moving on from neurological differences, let's tackle the technology. Patients needing things like long-term ventilators or tracheostomy tubes.
Right. This specialized tech is now really part of our pre-hospital assessment landscape. Take track tubes, for example.
They bypass the upper airway entirely. Direct path to the trachea.
Correct. And because they're a foreign body, they naturally stimulate more secretions. This makes them really prone to getting blocked, usually by mucus plugs.
And an obstructed tract tube is a genuine emergency.
Catastrophic. Immediate life threat.
This is where mnemonics can be lifesavers, like DOPE for tract obstructions.
Exactly. DOPE is fantastic for troubleshooting these. You run through it systematically.
Okay, so D is for?
Displaced, dislodged, or damaged tube. Did it come out? Is it halfway out? Is the tube itself broken? Obstructed? Is it blocked? Secretions, mucus, maybe blood. That's often the most common issue.
P stands for?
Pneumothorax. A collapsed lung. This is a serious possibility, especially if they're on positive pressure ventilation.
And finally, E.
Equipment failure. Check the simple stuff first. Is the tubing kinked? Ventilator battery low. Is the vent actually working correctly?
When you're dealing with O for obstruction and you need a suction, there are specific details to remember.
Crucial details. If you don't know the exact length of the tract tube, and often you won't, don't insert that suction catheter too deep.
Yeah.
No more than 1 to 2 inches, maybe 3 to 6 centimeters.
And the timing.
Critical. Never suction for more than 10 seconds at a time. And always pre-oxygenate before you suction and hyperoxygenate afterward. You want to avoid causing hypoxia.
Okay, let's switch gears to advanced cardiac support. Ventricular assist devices, VADs, usually LVADs, right? Left ventricular assist devices.
Yes, LVADs are the most common type you'll encounter.
So what exactly is a VAD doing?
It's a mechanical pump. It essentially takes over the work of one or sometimes both ventricles of the heart. It pumps the blood when the heart muscle itself is too weak.
And people have these either temporarily waiting for a transplant.
Right, as a bridge to transplant.
Or sometimes permanently.
Or as destination therapy, meaning it's the long-term solution.
Now, the really big implication for us in the field, the pulse.
Ah, yes. Because the VAD creates continuous blood flow, not the usual pulsing flow from a heartbeat.
It can be really hard, maybe impossible, to feel a normal pulse, like a radial pulse.
That's the major aha moment. It completely changes how you assess circulation. You can't rely on feeling that pulse to know if they're perfusing.
So what do you rely on?
You have to shift to other signs. Level of consciousness is key. Skin color, temperature, moisture. Are they alert? Are they pink and warm? And crucially, you need to assess the device itself. Is it running? Any alarms? What's the blood pressure?
Okay, the nightmare scenario.
Wow.
The VAD alarm starts blaring in the back of the ambulance.
Yeah, that sharp, distinct alarm definitely gets your attention. High stress. First, always assess the patient. How do they look? Then immediately check the device basics. Connection secure, batteries okay, is the driveline connected properly?
And there's usually support available.
Yes, VAD manufacturers almost always have a 24/7 toll-free support line. Don't hesitate to call them. That technical backup can be invaluable when things are going sideways.
Okay, let's shift focus for our last section. Less about tech, more about social structure. Patients dealing with poverty and homelessness.
A really important group. These social determinants have a profound impact on health. Lack of preventative care, poor nutrition, not being able to afford meds, it creates huge barriers.
The statistics are pretty stark, aren't they?
They are sobering. Even though numbers change year to year, we know millions live in poverty in the U.S., and hundreds of thousands are homeless on any given night.
And certain groups are at higher risk.
Yes, subgroups like the chronically homeless, veterans, LGBTQ youth face even higher risks. And the key thing for us, this whole population is significantly more likely to rely on EMS and the ED, often for problems that might have been managed earlier in primary care.
So how does that reality, poverty, homelessness, change our assessment on scene? It's got to be more than just being respectful, right?
Absolutely more. One big thing, often missed, is environmental exposure.
How so?
Well, someone experiencing homelessness might be sort of chronically adapted or
Mhm.
maybe masking signs. They might not show classic signs of hypothermia or hyperthermia because their body is just constantly dealing with exposure.
So you have to actively look for subtle signs.
Yes. Look for signs of prolonged exposure. Check carefully for pressure sores. Maybe immersion foot if they've been in wet conditions. Even if the weather seems mild that day.
And communication challenges.
Yeah, patients might be uncomfortable, ashamed maybe of their appearance or hygiene, poor teeth. They might mumble or avoid eye contact.
So how do you build trust quickly?
The key is therapeutic communication that normalizes their situation without being dismissive. Don't focus on the dirt or the smell, focus on their medical need. Saying something simple like, "This is a safe place, we're just here to help you," can go a long way. Gentle acknowledgement, not judgment.
And if transport is needed, there's a legal aspect too. You mentioned EMTLA.
Right, EMTLA, the Emergency Medical Treatment and Active Labor Act. Basically, it's the federal anti-dumping law.
What does it mean for us on the ambulance?
It means once a patient needs emergency assessment or treatment, we have a duty to ensure they get it, regardless of whether they can pay or have insurance. It dictates that hospitals with emergency departments must provide screening and stabilizing treatment. They can't just turn people away inappropriately.
But many of these calls might not be true emergencies, more like primary care gaps. Is the ED always the only answer?
Increasingly, no. And this is where the role of EMS is really expanding.
Oh.
You need to know about the social service resources in your area. And we're seeing huge growth in mobile integrated healthcare, or MIH, sometimes called community paramedicine.
What does that involve?
It often involves partnerships, hospitals, EMS agencies, working with shelters, social services, providing routine care, checkups, managing chronic conditions outside the ED.
So instead of just transport.
The EMT or paramedic becomes more of a navigator, connecting the patient with the right resource, which might not be the emergency department. It could be a clinic, a shelter with medical support, mental health services.
That really does change the job description.
It absolutely does. It's shifting us away from being just about rapid transport towards being, well, a key link in the whole healthcare and social support system. So as we wrap up this deep dive, I think the main takeaway, the philosophy, has to be treating every single patient with dignity and respect. Doesn't matter if they have complex tech, are facing homelessness, or communicate differently.
And remembering the caregivers.
Never forget the caregivers and family members. Their knowledge is gold. They know the baseline. Our job is really assessing the change from that baseline.
And it feels like this landscape is only getting more complex.
Yeah.
Chronic care at home is growing, and our role is growing with it. MIH, community paramedicine,
Yeah.
it's way beyond just transport now.
Mm.
Preventative care, chronic disease management.
It really is. Which brings us to a final thought to consider. Given this shift, with increasingly complex technology in homes and these deep social challenges impacting health, how do we need to evolve? How does our training, our professional development need to change so that we're not just first responders, but truly effective navigators of all these complex health and social resources?
That's a big question.
It is. It's a demanding evolution.
Yeah.
And it's fundamentally redefining what EMS provides to the community.